Hello, it's Dr. Garth Fisher with The Cutting Edge, and I'm here today. My guest is Dr. Brad Jabour, a leading neuroradiologist and founder of Medical Imaging Center of Southern California and Smart Brain and Health. He's a pioneer in developing the zero-rad whole-body MRI, as well as the latest developments in whole brain MRI and smart brain scan. Dr. Jabour has integrated these cutting-edge imaging techniques into protocols for patients and the maintenance of their health, both mind and body. Radiology has quietly become one of the most powerful and sometimes misunderstood tools in modern medicine. From advanced brain imaging to whole body scans that can detect disease before symptoms ever appear, imaging now plays a critical role in prevention, diagnosis, and patient safety. Today, we're going to pull back the curtain on what imaging can really do, what the public should be asking for, how to avoid unnecessary radiation, and how patients can protect themselves by being informed, not afraid. This is a conversation everybody should hear. Dr. Jabour, welcome to the show.
Thank you very much, Garth. It's a pleasure to be here.
I've always wanted you here. It's such an exciting and important conversation to have with you. And just to start off and say, I've always been very grateful you were part of the team that saved my life over a decade ago because of the very things we're going to talk about today. So it's very, very important to me that the public understands all this. And it's I think everybody should stop and listen to this. But I want to also say that this is a radio show. It goes on for 60 minutes. And he's a radiologist. He's got a lot of images that are very helpful, very fascinating, and he wants to show those. So at the end of this, there's going to be a continuation for 30 minutes that you can see on the podcast, YouTube, or Instagram, Garth Fisher, MD Cutting Edge. And there's going to be an additional 30 minutes, obviously not covered on the drive in the radio. So we're going to get to that after, and we're going to have you on for many shows. So let's get started with just some questions about, Brad, many people think of radiology as just reading scans. What does modern radiology actually involve today?
So radiology is an old term from the early days when Röntgens or X-rays were discovered, but it has moved far beyond just an X-ray to using many different techniques to look into the body, create beautiful high-resolution images that shows normal anatomy and very early distortions of normal anatomy which lead to pathology, whether it's using ultrasound, CAT scans or CT, which requires a little radiation, or whether it's totally zero radiation using MRI and all the new MRI or magnetic resonance techniques linked with machine learning or artificial intelligence to really dig in and find very early disease even before it ever could be discovered before now.
Yeah, I know your center in Santa Monica has it all. I've been there, you know me, I'm coming in there all the time, checking and looking under the covers, trying to find the crumbs, and you've been so good and your team is so great. What's the difference between general radiology and neuroradiology, and why does that distinction matter to people?
Well, a neuroradiologist has to be a board-certified radiologist. So in general, any neuroradiologist will be a medical doctor having gone to a medical school, then performed a residency, usually in surgery or internal medicine. Following that, there's 4 years of training dedicated to imaging the whole body. So any neuroradiologist is also a general radiologist. Mm-hmm. They have to be board certified in general radiology. Then a small percentage of people who are board certified radiologists are eligible to become neuroradiologists by performing fellowships in academic facilities where they only work in the field of the brain, the spine, and the head and neck, imaging only the central nervous and peripheral nervous system, or the brain, with all the various imaging capabilities.
So how much does the experience of the radiologist matter compared to just the technology?
Well, I say it's always team, technique, technology, the 3 T's.
Oh,
you can't just have a brilliant guy reading scans when the production of the scan might be old-fashioned or garbage. There's a lot of variation in capabilities between MRI machines across the country. So an excellent neuroradiologist in an average machine is not as good as, or maybe is problematic, just as a fantastic machine with a average radiologist not be that good. You really need all 3, and you need the technological team that knows how to use that equipment. So it's not an isolated guy on the horizon. It's really a team approach to get great images.
That's why I come to you guys, because I feel like you have everybody, and I've been very thankful. And again, I had this close call, I would say, with death over 10 years ago that I was so appreciative of you and the team. And, I tell everybody that, they're looking into anti-aging and wellness. And I said, one of the most important keys that people are really not paying as much attention to is the early detection, the screening. Because, I tell people, you want to catch the burglar in your driveway, not at the foot of your bed in your bedroom. You really want to know what's going on before, while you still have a chance to, take care of things. So when they come to a place to get, let's say, MRIs, CT scans, X-rays, some people fear for, radiation risk. Could you, what studies give what radiation? How much of what kind of risk is that really?
The way to think of it is that there are thousands of doctors, internal medicine, family doctors, and they have patients with actual diseases, right? That's not so much the preventive medicine. That's patients with real problems that need a spectrum of imaging modalities to get to them.
Broken bones.
Or tumors that are well known, and they're getting chemotherapy, and you've got to follow it with a combination of ultrasound or CT. And so you mix and match the appropriate imaging procedure to this particular pathology. That's separate from what I call imaging the worried healthy, or let's say the concerned and intelligent healthy. Mm-hmm. That's a whole nother spectrum of thought process in terms of preventive imaging for longevity. Mm-hmm. So there's two components. One is imaging diseases that are well known, whether it's musculoskeletal, oncologic, cardiovascular, versus imaging, we call them the worried healthy. The worried healthy, are they justified in being worried is the question. And
I'm worried healthy.
Maybe we would talk about that.
Yeah. Well, I think people also unknowingly accumulate radiation over time, flying, or how do they, is that true? And how do they protect themselves?
Yeah, living out, just being in the sun, there's ambient radiation, flying continuously, there's a slight increased risk in radiation. X-rays, we generally try and perform non-X-ray based imaging whenever we can. There are certain diseases that have to have the CT, the imaging, the radiation, some component of radiation.
Right.
For instance, coronary angiography, the heart, that's still the biggest killer in America, atherosclerotic heart disease. And MRI, no matter how good it is, still is not able to see that very early calcification, and is not as good as the CT coronary angiogram at quantifying the degree of stenosis in the coronary artery, which is what kills people.
Right.
Or it's the ruptured plaque, the soft plaque. And so we can see the soft plaque on CT coronary angio. Unfortunately, does require little radiation, but with the new techniques, this radiation is come down tremendously since decades ago.
Right. And the MRIs have no radiation.
Zero radiation.
Zero radiation. So, and
hence what we call our full body MR, the zero rad full body MR.
And that's been around for many, many years, because I remember a long time ago coming in to do that. And I know there's a recent group that advertised pretty heavily about doing their MRIs, and you've been doing that for a long time, I believe.
Yeah, we pioneered it. I think we're the first in the US to have developed the full body MR 2008, and we've done thousands of them. And there are many other not many other. There are one or two others that have popularized it, but we remain the gold standard boutique one-on-one patient interaction, very different from the way some of the other places do it, which is more mill philosophy.
Yeah, you guys have got a really outstanding staff that make you feel at home, and I think that's great. This is Dr. Garth Fisher on the Cutting Edge. I'm here with a pioneer in radiology. He is Dr. Brad Jabour with Southern California Medical Imaging. And
it's actually Medical Imaging Center of Southern California.
Oh, Medical Imaging of Southern California. Yeah. I will have to correct that then. Yeah. Medical Imaging of Southern California, and also Smart Brain Health and Zero Rad Whole Body MRIs. And let's keep going with the questions. But getting back to the radiation, if you have a CT scan, how much radiation is that? Do you have to worry about that? Or?
Well, there's different kinds of CT scans. For instance, people who are smokers or exposed to ambient smoke as they were growing up, their parents. The recommendation is to get a low-dose chest CT, very low radiation, much lower than it used to be. The new CT scanners have made it so small that it's inconsequential, really, in terms of risk. The risk from the tumor is far more than the risk from this very small amount of radiation. So it's called a low-dose chest CT.
Right.
This is for people who have some risk of lung disease. I don't think everybody needs to get a yearly low-dose chest CT. We offer it as part of the zero-rad full-body MR, one little piece of radiation if there's a lung issue, because MR, the one place MR is not better than CT, is in the chest.
Right. So, MRI, no radiation, but if you see something that's worth looking for that you have to look for, you do another step.
More importantly, if there's a family or if there's a clinical history, we try and curate the study and add that on if there's a reason to do the low-dose chest CT. Otherwise, it stays a zero radiation whole body scan.
Okay.
But if they did smoke, for instance, or had a job that was exposed to noxious elements like firefighters or people who worked in certain industrial environments.
Yeah. Well, it's maybe hard to answer, but do you think, I don't know if it can be answered, do you think CT scans are overused in emergency rooms or routine care? Or should a patient politely push back on that? I guess you don't know because you don't know what the situation is.
Yeah. I think that appropriate use of CT, and, the guys in the emergency rooms are under pressure, and I wouldn't second guess them, because if you, for instance, have a hit on the head, the only way you can tell if you're going to develop a subdural hematoma is a immediate non-contrast head CT. We don't want people second guessing the ER doctor.
Yeah, you have to do that. Yeah. It's worth it, risk versus benefit. Yeah. Are there safeguards in place that help high quality imaging centers such as yourself? What are in place to kind of minimize radiation risk?
Well, no, there's strict criteria. You have all sorts of governmental agencies monitoring the radiation capabilities of your machines, which have to be what's the right word? Compliant with the government standards. Yes, so there are strict criteria.
Okay, I'm sure you follow those. I've been in there and I saw a brand new machine you had in there the other day that was looked like it just got taken out of the box.
And they're extremely expensive to maintain and keep things running at the optimal level of of capability.
Right, and people need to take off all their jewelry and metal before you go in there. I'm sure that's...
Yeah, the MRI scanner is dangerous to go in if people are not aware of the risks. You can't walk in there with any kind of metal object that can fly off and actually kill somebody. So we know about MR safety. No metal objects.
Right, fantastic. When you're looking at MRI versus CTs, which one is superior? When is CT a better choice? When you choose MRI, which of course is no radiation at all?
It's like that's a difficult question. It's like asking which of your kids is your favorite. They're both very critically important. However, MR is steadily becoming the one shop for all diseases. Mm-hmm. There's certain diseases, however, that CT remains the key instrument to find the disease. And that's for severe, or not even severe, but risks for coronary artery disease, both for screening with calcium scoring and for detecting the soft, dangerous plaque in the heart. We do a CT coronary angiogram with an AI-enhanced program where we can measure and quantify the soft plaque. Not only the soft plaque, but the calcified plaque, which looks bad, but it's not the risky one. The risky one is that soft plaque that can rupture. And so MR can't do this yet. It may, in the next 5 years, develop a capability to compare with CT, but that's the one area where CT remains the leader. So of all the diseases in the body, MR is almost always better for everything. I would add one other area where CT remains the key tool, which would be either early lung nodules and whether they are becoming cancer. And number two, in patients with kidney stones where they get sudden, unbelievable abdominal pain And the only way to see that stone quickly is with a non-contrast CT scan.
Hard to imagine they can even sit on the table still if they have the kidney stones.
Oh,
That's
it's
the worst.
the worst pain, yeah.
It's the three worst pains I've ever heard, from being a trauma surgeon back in the day. The three worst pains are childbirth, kidney stones, and having a chest tube put in your chest.
Yeah.
With
There's one other area where you still need radiation, and that's unfortunately, and women often really push back on this, but in the breast, mammography is the only way with a little bit of radiation to see the very, very early microcalcification seen in the breast. You and I have had many patients where we've had to struggle with that.
Right.
And there is some hope in that very high resolution ultrasound is starting to see almost as well as a low dose mammogram,
Right.
but not quite there yet.
Okay, so another thing I think is important for the listeners or viewers. I'm really a big advocate, as you know, that we talked about, of pre-screening and early detection. So when would you advise a family member to go in for a total body MRI like I've done as a screening test to see what's going on? Is there a particular age? And then I want to get into, and I don't know if you can answer this, usually probably doctors get referred to you, but what pain is like, you need to come see me, or, when did you advise somebody to be screened total body MRI?
So a whole body MRI is not a covered procedure. Unfortunately, insurance companies don't provide screening, whole body screening. And the question of being responsible as a imaging person in giving good information, so you're not scanning everybody on these expensive scans who may not have a likelihood of finding a significant abnormality. Mm-hmm. So, for instance, teenagers, 20 to 30-year-olds, and 30 to 35-year-olds generally will not have the kinds of devastating diseases, early cancers of the prostate, the pancreas. There will be some, but a small minority. The logarithmic increase in disease occurs when you get into your 40s. Mm-hmm. So in my opinion, around 40, is a good time to get a whole body MRI, because it creates a very good baseline of where everything is, what everything looks like, because all of us, as we go each decade from there on in, will develop some issues of which many might not require action or intervention, but unfortunately there are many that we'll see: the very early pancreatic cancer, the tumors, the aneurysms in the brain. That's, having said everything I've just said, aneurysms in young people are devastating because they rupture in their 20s, and people die very quickly from a ruptured aneurysm, and the whole body MR detects that. So if you've got a family history of an aneurysm, so it's not one size fits all for everybody.
It really doesn't. Family history versus symptomatology versus this. And, the three reasons people die are trauma, heart disease, or cancer, basically. And, I do a lot of tests. I look at the top organs you could get cancer in. I want to know what's going on with them all the time. I draw my blood every 3 months. I have a lot of friends that I send in. I say, just tell Dr. Jabour to do the Garth Fisher studies. And then they come in and they're lined up on that calendar. And if you can do it, I'm not one of those, because I believe you're ethical, and I have doctors that are ethical. I'm not one of those that believe that I'm going to find something and somebody's going to chase something that's unnecessarily. I mean, I'm a physician too, and I know when's enough's enough. But if you see something, you just know what it's what do you need to watch?
Yeah.
So I think it's important to go in and get this done. And like you said, it's not one size fits all, but maybe in your 40s you start seeing different things.
I think in if you've got a family history of somebody having died from a ruptured aneurysm, then we know there's a genetic predisposition to having say a cerebral aneurysm. So then a young person could just get, instead of a full body MR, you get an MRA of the brain, in that case. So and that's usually a sensible family doctor or an internal medicine doctor would catch that and say, let's do a screening MRA. So that's, not covered by, that's covered by insurance generally. So it's hard for me to give you a rigid sense of
course.
It. But I would say by the time you're in your mid-40s, if you can afford it, people should get a full body MR.
Yeah, I agree with that. And we're going to get in later about the neuroradiology, which is so So fascinating with the technology that you have with mental illness and everything else. So, what advances in MRI technology have improved the accuracy or patient comfort in recent years?
Wow, that is a very good question. So, I talk about the three major advances. One is an engineering advance, the hardware, the unbelievable machines made by Siemens, GE, and to some extent Philips, where you have these massive magnets that are able to create the magnetic field and image function, functional imaging using MR. We've been able to do structure for a while, which is looking at a building, being able to photograph the building, say, oh, that's a 30-story building. Now what we can do is look at the building and measure how the HVAC is working, the air conditioning, is there lighting, is everything
Function.
working, and
Yeah.
we can assess that structure, the body or the brain, not only in terms of its structural architecture, but in terms of its function. So huge breakthrough on that, especially engineering matched with AI. AI is now able to take an image and actually find the abnormality without the neuroradiologist.
Are you worried about losing your job? Is AI going to come in and take over? I mean, I'm sure it's
don't
just
think so.
amplifying everything.
No, I think that the analogy to me is like back in the 1900s in New York City, there was famous photograph, there were many horses and carriages in one car. In 1912, there was one horse and carriage from a similar photograph and only cars. So where did those people go who made horse and carriages and drove and groomed the horses and fed the horses? They re-engineered roles for themselves in the new economy, which grew much more than the agrarian economy. So I'm an optimist because you can choose to live with worry and be pessimistic and be right, or be optimistic. And even if you're wrong, at least you lived happy.
Right. Well, I won't think about it till I walk in your center and see an Optimus robot greeting me and shaking me in.
That should happen.
Three or four of those. Whole body imaging, like we talked about, is becoming more common. Is there anybody who doesn't need it, or you can't be, clear line on that either, below 40, what?
Yeah, I think that the whole body MRI, it would be nice if it could be affordable to the point that everybody could get it as a routine exam at some point in their 40s. I mean, I foresee that happening. As the scaling of technology, it's sort of everybody couldn't afford, a car in the 1920s. But today it's unusual if anybody doesn't have a car. And I see the technology expanding to the point where it will be integrated into the basic medical, yearly medical, I think eventually yearly medical screening of people.
Now, sometimes insurance will cover it if they're complaining of a headache or they're complaining of something in their abdomen, or is there something?
No. The whole body MR, which covers every system in the body, brain, head and neck, chest, heart, abdomen, pelvis, prostate, uterus, ovaries. There's no one scan other than the whole body MR that can get every part. Insurance won't cover that, doesn't cover that. If you have a specific symptom related to one specific body part or organ with the history and the clinical notes from a referring doctor, the insurance company will pay for that.
Okay.
But no doctor can refer for an insurance-based full body MR.
And with this total body MRI, you feel like you can see early changes that would be early enough that you have a lot more, leeway to try to cure.
Yeah, I mean, we documented all the people's lives, I believe, that we've saved, just looking at aneurysms. Young people with circle of Willis aneurysms off the middle cerebral or anterior cerebral artery. In a year, there were 7 patients. These are people in their 20s and 30s. So that why they got a whole body scan, I don't know. There were, people who could afford it, I guess, or maybe they knew they had some history, and
Obsessed with their health, and they want to live a long time. They're happy.
Yeah.
You know,
I don't encourage people in their 20s to do it
right.
For that reason, but we did discover these aneurysms on the MR angiogram. And, not to mention our relationship, but imaging the pancreas is another area where it's a silent tumor that grows. You don't even know anything about it. All the lab tests are negative, and we see dozens of precancerous lesions in the pancreas every year.
Yeah, precisely how you saved my life, and thank you for that. I'll never forget that day when we saw that little tiny tumor, and we watched it for a bit, and then it was time to take it out. And I had a fantastic team with you, I feel, as the lead person in that, and that was well over a decade ago, and been happily ever after. Yeah, time flies. This is the part that he's really excited about the most, probably. He loves the brain, and it's just fascinating how fast this technology has taken off and what he can actually do. And just this is for the average patient, a person with headaches, dizziness, or memory concerns. Where is brain imaging warranted?
Yeah, brain imaging is MRI is the Rolls Royce of understanding what's going on in the brain, not only structure, but function. Mm-hmm. So we can see the shapes or morphology, but more importantly now we can actually measure the functioning brain and see, for instance, people with memory loss have disruption of the brain networks. The brain's like an electronic pump. Mm-hmm. There are these networks that are connected to each other in certain ways, and using the imaging, you can see the disrupted networks earliest using MR and predict.
It's in color, isn't it?
Well, the MRI can measure the hubs of activity in the various neurons that are separated from each other, which are connected by wires. Mm-hmm. It's sort of like looking at the Earth from a satellite and seeing the airports in
busy
each
activity.
Area, and you can see the airports where their planes are landing versus the flight paths. And so we're able to, with MR, see the hubs. Let's say LAX is taken out. Mm-hmm. Suddenly it's black. And now everything's rediverted to San Diego and San Francisco. Right. We can see the same thing in the brain with, say, Alzheimer's, where certain areas are taken out and the hubs are not functioning, and you get disrupted networks. The question is, once we find that problem, can we fix it? And there's amazing prospects coming to help people stimulate and preserve brain function using neuronavigated TMS, where we use that GPS of the whole brain and target the specific hubs that are, let's say, are vulnerable to try and keep the neurons healthy, stimulate neuroplasticity.
And also, a lot of people are taking antidepressants these days, and with this technology that you have, this is something where you can really evaluate people, how the brain thinks, how the people are depressed, maybe people that are suicidal. Where's your role in that? What can you do?
So depression is a real scourge in that it's like a tip of an iceberg. People that you see are depressed are a small percentage of those that are actually depressed, who hide it or conceal it. And there's a real problem with antidepressant medication. And now that we can actually image depression, you don't have to sit on an old-fashioned psychiatrist's couch and talk to somebody for days to try and get a diagnosis. We can image depression, and we can see it. We find the area, and then we fix it with a completely biologically healthy, targeted, modulated device called TMS, transcranial magnetic stimulation, where you target a magnetic field on the neurons that are sluggish, that are not working properly, and you can fix the depression. And
in some cases,
in many
really?
cases,
Wow.
the majority of cases that get significantly better.
Wow.
Now, it may not be durable forever. Like after 8 to 10 months, sometimes patients need a small second, let's say, refresher course, because the initial treatment's a week of targeted treatments 5 times a day for 5 days, 25 treatments.
Wow.
But it's safe. It's relatively painless. It feels like a woodpecker pecking at your skin. But target, no.
I'm not sure that's painless.
It's a little bit irritating to the patient, but they tolerate it well, and that's using MR with targeted neuronavigated TMS to treat depression. So that's a huge field that's making big inroads in mental health.
Yeah.
The same technology, functional MRI, can be used in Alzheimer's, where we can first detect the fact that the patient's at risk for Alzheimer's using an MRI study, which is part of our full body MRI scan.
What age would you say would?
Well, it only tends to you only get the early phases of volume loss in the hippocampus in your late 40s, 50s, but the test is totally benign. It's part of an MRI of the brain. You could just do an MRI brain plus evaluate for hippocampal occupancy. We incorporate that in the full brain MR because in the late 40s, 50s is when you want to know your risks for these sorts of things. People say, well, what happens if I'm at risk? I don't really want to know because there's nothing you can do for Alzheimer's.
Well, you won't remember.
Well, no, there's nothing. They think possibly there's nothing you can do because there's no cure for Alzheimer's. But there are things you can do to slow brain degeneration if you're unlucky enough to have the tendency to be heading towards Alzheimer's.
Can you see hippocampal atrophy on a total body MRI?
We incorporate it in our full body MRI, yes.
Okay. So what about using modern neuroimaging that you're speaking about to detect early signs of stroke, aneurysm risk, and other neurodegenerative diseases before the symptoms appear?
Yeah, so take those one at a time. The aneurysm risk is done as on every full body MR. We do an MR angiogram of the intracranial vessels when we can definitely detect any aneurysms. The second thing you mentioned was
aneurysm risk, signs of stroke.
Well, signs of stroke are more clinical situation where somebody's having TIAs but risk of stroke certainly we would see because atherosclerotic vascular disease is seen often on an MRA, although the most sensitive test would be a carotid ultrasound. And in our facility, we do offer the carotid ultrasound in the neck for screening as part of a full body MRI in many cases where we look at intimal muscle thickness and we can tell if there's a risk for, just like in the heart, but in the brain, the vessels to the brain, it's easily measured with a safe ultrasound as opposed to the heart where you've got to do a calcium
I did that
score.
one as well. I got a little bit off the menu from and it turned out great, which I'm happy about. So what are the most commonly missed findings on brain imaging when scans aren't read by specialists? And I was going to ask you also about actually thrombotic versus hemorrhagic strokes. Which one's worse? You see those a lot, don't you?
Well, strokes are either, the cause of a stroke could be embolic phenomenon from, say, an arrhythmia in the heart or a valvular issue.
Atrial fibrillation.
Yeah, atrial fib or any kind of arrhythmia. And that would be an embolic clot,
right?
Clotting off a vessel, usually distally at the gray-white junction.
Right.
The other kinds of
hemorrhagic.
Yeah, the other kinds of strokes are those secondary to high blood pressure that you just blow out a vessel and boom, there's blood dissecting through the brain.
That's worse.
And that's not so nice because that's, well, then none of them are good. But, but the acute hemorrhagic stroke from high blood pressure, which is avoidable because you just got to manage the high blood pressure.
Right. And what are the commonly missed findings on brain imaging when scans aren't read by specialists?
Well, I think, we have to be a little humble about this. The best neuroradiologists can miss findings. Because there's so many images and it takes incredible concentration to read scans and there's subtle findings. So it's not impossible to miss findings. But the common or difficult things to miss or that shouldn't be missed would be in the brain aneurysms, I would say, because unless you do an MRA when you do a regular MRI, the aneurysm can be seen, but it's often imperceptible, and is only well seen through what we call the retrospectoscope, the mythical device that you can look back and say, "Oh wow, I see it now." But
Use AI too, doesn't it help? I mean, is AI used in this?
well, now AI is definitely going to have a role in detecting certain diseases. It's going to be delayed a little bit in that type of vascular imaging.
Okay.
It's good in the lung, where you've got a relatively stable, non-moving organ, where the pattern recognition of the machine learning of AI is able to look at hundreds of thousands of X-rays and say, that's what a pneumonia looks like, that's what a cancer looks like. And now you feed the individual scan into the AI, and it'll say, yes, there's a lesion, it's a nodule, it's a cancer, or this one's a pneumonia. In the brain, it's pumping. It's a moving organ, the brain.
Right.
And these vessels, throbbing, and you may get. It's a little more of a challenge, but AI is going to get it ultimately.
Hey, we're still in the dark ages. It feels like but it'll get
I
better
often
and better.
say it's like the very first voyage of discovery, where Columbus went out thinking he was heading to India, and he came across the Caribbean islands. And with AI, just heading out across the Atlantic.
Right. It's exciting. I love being connected to you so I can hear all about it. So what a lot of people hear about incidental findings. What does that mean?
So when you have a scan for a particular symptom, let's say it's low back pain, and you see a disc herniation, but you happen to also see a big cyst in the kidney, you came in to get an MR of the spine, which has the problem, but now, lo and behold, here's a tumor in the kidney.
That's
Now,
an incidental finding because it's extra.
Right.
Yeah.
And many of them are benign, and we don't have to worry about, if you got the experience, not to chase it down. It's a benign, nice, morphologically homogeneous cyst with no nodule. And you can reassure the patient, yes, there's a tumor in your kidney, but this one you don't have to worry about.
Right. Yeah, incidental findings, I think, are probably quite common, and people get excited about it. But when you talk to the doctor, such as yourself, you can explain those differences. And again, it's good to know what's going on inside your body and where. And there's just so much to talk to you about. That's why I want you to come back again and again and go through all these, even the new innovations that are going to be happening.
By the way, this is an unbelievable studio you've got here.
Oh, thank you.
I feel I'm actually in a resort.
What makes it beautiful is the fact you're in here helping people, giving your advice. I'm a big believer in screening for early diagnosis and detection, and I've been living that life for many years, and I will continue to do so. And also, I always advise my friends, and I think his center is great. I'm sure there's others, but I love Dr. Jabour's center. So we talked about incidental findings. Those are quite common. How do patients interpret reports, without spiraling into fear after reading this medical stuff that they don't understand? You're quite calming, and I know you help everybody, but patients don't understand, and they're worried a lot. What do you do?
Well, there's two groups of patients. Those that come to our facility from a referring doctor for insurance-based business for a known medical problem. We often will stay in our own lane and not usurp the primary doctor's role of taking our report and interpreting that for the patient.
Right.
But we do make ourselves available to help explain the findings. So we do offer that. I believe radiologists should be more actively involved in communicating that and allowing the patient to actually see the images when they come to our facility, rather than just getting a written report. We also send all the images to a portal where the patient can see all the images with the reports. Now, they often say, holy, what the heck does this mean? So we make ourselves available to them for a consult one-on-one on Zoom. That's on the traditional imaging for known diseases with insurance. On the full body MR, we're pretty unique in that we do a one-on-one consult with the patient beforehand. So because we're not just a one-trick pony, not just an MRI, we can in talking to the patient, evaluate whether there's a cardiovascular risk as well, and offer the carotid ultrasound for the stroke screening, as well as the coronary calcium scan, while they get, at the same time on the same visit, that they get the zero rad full body MR.
Right.
So, but that's because we're more boutique oriented rather than multi-site all over the country. So we have multimodality, and we can solve the issue, and we go over the study with the patient, so there's not any, anxiety. Other than if there's a process, we can help them get into some channel that gets their problem taken care of, with referrals to the best doctors in LA.
One of the other things that there's so much, but I mean, you guys also have a great center. There must be so many knee injuries from professional sports. You've got skiers and basketball players and that are ACL ruptures, knee problems, shoulder, rotator cuffs. I mean, you have imaging for that.
We really image for, I won't mention names, but for the sports teams in LA,
Of course. Yeah, and I know I tore my rotator cuff, and, I got my imaging there as well. And, of course, mine was repaired perfectly. So what are there questions that maybe a patient should ask when they're trying to find a really high-quality imaging center? What should they be aware of or ask, or when they know they're in the right place? And
I think there are many good facilities all over California. We're blessed by having great doctors in the whole of Southern California. Mm-hmm. I think the main difference between, say, an outpatient facility like ours, which is not bogged down by all the bureaucracy of a hospital, let's say, sometimes inconvenient, even though UCLA has fantastic equipment and doctors and what have you, it's often intimidating for a patient to go because you don't really get to talk to the neuroradiologist or the radiologist, and you're dealing with a bigger bureaucracy. So some people don't mind that, but I think if you're looking for convenience and an environment and interactivity while still getting state-of-the-art imaging, we are one of those facilities.
You're a boutique, and what are your hours? You open, what kind of hours?
We're open 7 days. No, actually, we're 6 days a week. We stopped doing Sundays, but we do open on Sundays if needed. There are several urgent care, without mentioning names, the new trend of concierge urgent care. Mm-hmm. In town, we do the imaging for them on Sundays.
And you're in Beverly Hills and Santa Monica.
In Beverly Hills and Santa Monica,
why does having subspecialists like brain, spine, body, cardiac under one roof improve the outcomes?
The collaboration between specialists really helps enhance the quality of our facility, in that we've got oncologic imaging, musculoskeletal imaging, women's imaging, and neuroradiology as well, all in one environment. And often a disease process doesn't just affect one organ. And so if you have the ability to have a team look at something at multi-specialty across specialties, that's an advantage.
I think you have the advantage also. You have a setup, I know, where you're communicating with people specialists around the world. You're sharing screens and studies with people. I guess they've already said they want to collaborate with you, or?
Yeah, we stay very connected with cutting edge leaders in all the fields of that we do. A great example was when prostate imaging about 6 years ago made huge strides into having patients avoid until the mid 2010, 11, if you had a prostate cancer with a raised PSA, you had to get this uncomfortable, very invasive biopsy with 12 needles through your rectum into the prostate.
Exciting.
And the guy who developed, or a whole team who developed it, brought it to us very early. And we were parallel with UCLA in developing multi-parametric prostate MRI, which was the sort of equivalent of a virtual biopsy of the prostate, where you can see the cancer with no needle. Mm-hmm. And then if you do need to biopsy it, you put one needle through into the tumor, not 12. Mm-hmm. And so that's a great example of what we brought to Los Angeles very early through our connections across the world.
Let's see here. What else can we talk about as far as like women's screening? Going back to men, you have certain points you have to worry about certain things, I think. And again, what's going to, if you're enjoying your life, you want to live a long time, there's three things that really you got to watch out for. One's trauma, one's cancer, one's heart disease, right? And for men, when you get a little older, you worry about prostate cancer. So you have to look at those PSAs and your blood levels. And what about women? There's mammograms. You're worried about ovaries, uteruses. Tell me how you screen for women.
I don't want
you
to
have a women's center.
But I want to stay on men for a second, because men have been, they're stoic. They don't. Women really took the problem of breast cancer and they advocated and they changed medicine and they got everybody on a screening consciousness, saved many lives. Now, breast cancer is no longer a death sentence.
No.
If you catch it early, it's just a simple treatment and you treat it.
And that's 1 in 10 women is around something.
Whereas before it was people would die in 6 months, because it was too late when they caught it. The same with prostate. Men are kind of brought up, unfortunately, to be kind of dismissive. They're tough. They don't want to know. But prostate, every man will get prostate cancer if he lives long enough. It won't kill him necessarily, because fortunately it's not an aggressive metastasizing tumor. But if it gets out of the prostate, that's very serious. So we know that the tumor in the prostate will sit there as with low aggressivity for quite a long time, which gives men the opportunity to image it, because the PSA in a significant number of patients will be negative, people who have prostate cancer. So I believe that a prostate MR should be integrated into the treatment or into the management of men in their middle ages.
Yeah.
That's why we offer it as part of the zero rad scan. It's done automatically.
Right.
But if you're not going to get a full body MR, you should work with your doctor if you're 50 plus, even if your PSA is negative, to at least consider doing a multi-parametric prostate MRI.
Okay.
It's in the same place where breast was in 30 years ago in the consciousness, and eventually men won't die from prostate cancer when this mindset is well established. So getting back to women.
You have a women's center.
Yeah, we have a full women's center. I'm not the expert on women's imaging, thank God. I have a fantastic doctor there.
Right.
And she's Dr. Iyengar is, I think, one of the leading breast imaging people. She's super smart.
I love her. She's great. And so you guys do everything from biopsies to
we have
ovaries.
a massive screening program with ultrasound for dense breasts, the screening mammogram, and then the diagnostic mammogram. If you see problematic dense breasts or areas of calcification that are worrisome, we have dedicated ultrasound techs using the high-resolution ultrasound to separate out the dense breast tissue from tumor. And then we are, I think, the only facility in LA, the outpatient, that also has an MRI scanner, because breast imaging now requires MRI to really see multi-local. If you've got a breast cancer, you could have a second breast cancer.
Especially lobular cancer.
Yeah, and the MRI is required. So we have all that as a one-stop shop, and we do all the biopsies. So all of that is fully covered in our medical imaging center in the Santa Monica location. Where
I just hear this, and it just goes back to, I'm amazed. Nothing works without us, right? If we're not around, then what else is important? Your family needs you. We need us. And people are reminded to take their car in at 12,000 miles, 24,000 miles, 36,000 miles. You constantly look at your car, and a lot of people are looking at their finances and, what's my stock market doing? I got to meet with my accountant for my portfolio. But, really your health is more important than all of those, and you should be doing the same thing for that. So I encourage people to do these kind of things. What imaging advances are coming in the next 5 to 10 years?
I'm so glad you asked that, because metabolic health is still indirectly the biggest cause of death in America. Bad metabolic health. What is that? That's a spectrum of diseases related to insulin resistance, or let's say glucose levels that run too high for a number of reasons, all related to the pancreas, And the fact that using the Krebs cycle and the various glycolytic pathways, you dump glucose and turn it into fat, and it creates this massive visceral fat in the central abdomen, and you get fatty liver, and then the fatty liver connects into the inflammatory situations, and you end up with hyperinflammatory processes in the body, and it accelerates all the horrible things. You get zombie cells, which can become cancer cells. You know, the metabolic syndrome affects all the organs, and we can image that.
I'm glad you're talking about that because it is true. And this is Dr. Garth Fisher with The Cutting Edge. I've been here with Dr. Brad Jabour, who is a neuroradiologist and an expert and a pioneer in imaging. It's been a great piece. We're actually going to continue. This is for the radio show, but there's going to be an additional 30-minute segment going over fantastic slides. Dr. Jabour, what are the three biggest killers in America today, and where does imaging save the most lives?
I would say diseases related to obesity and metabolic health indirectly kill more people. Second would be coronary artery disease, still the scourge statistically. And third probably is trauma, or maybe, I haven't checked the NIH statistics, it might be fentanyl or things related to overdose.
Okay. Dr. Jabour, at what age should healthy people start to do screening imaging even without any symptoms?
Well, this is a complex question because your lab results and your family history might sway you to an earlier date if you have a bad family history or a predisposition to certain bad labs. For instance, if you have out of control blood lipids, you might start screening for heart issues earlier. And if you have a family history of colon cancer, you might want to be doing your colonoscopies earlier. The imaging, whole body imaging, I say as a rule of thumb, if you can afford it, mid-40s would be when you get a full body MRI. I'm not saying young people wouldn't benefit, but it is less likely to show abnormalities other than the aneurysms that I talked about earlier, which can be devastating.
Dr. Jabour, what cancer is the hardest to detect early, even with modern technology?
Well, there's certain cancers that won't show up initially in the imaging, the leukemias. Eventually they'll have some...
Pancreatic, thyroid?
Yeah, I'd say pancreatic cancer is one of the most difficult cancers to catch early because it's got paucity or let's say few symptoms, and the imaging in the pancreas can be very tricky on an average abdominal scan. You have to do the dedicated pancreatic protocols.
I know these are hard, quick ones, aren't they? So what's the most Dr. Jabour, what's the most dangerous false reassurance patients can get from a normal blood work?
The normal blood work can be an absolute camouflage of something terrible happening because you can have all sorts of terrible diseases with normal blood work.
That's true. I knew that was a tough one. You're like on Jeopardy. Dr. Jabour, if you could recommend one scan that saves the most lives, what would it be?
I would say it's the screening mammogram.
Okay. Dr. Jabour, is fear of radiation from modern imaging justified or outdated?
Justified in that you should be doing judicious use and wherever possible using alternative imaging to radiation.
Like MRIs.
Like MRIs. But sometimes there is no alternative, such as a mammogram.
Dr. Jabour, what deadly disease most often develops silently without warning signs?
Pancreas is the one that jumps out at me as being the most devastating, but colon cancer is another. Ovarian cancer is another one.
Dr. Jabour, are you seeing serious disease appearing in younger patients more often?
Anecdotally hear that there's more young people getting breast cancer at the moment from my imaging, female imaging specialists. I'm not sure if it's related to fertility meds or what it's actually due to, but they do report breast cancer more commonly discovered in younger ladies.
Dr. Jabour, in one sentence, what should every healthy listener know about imaging?
should know that in the appropriate setting, clinical setting, that there are amazing tools if the team, technique, and technology are in place where you get your imaging to not only see the normal anatomy but find whatever pathology might be there.
Okay, Dr. Jabour, it's kind of the exciting time now where I know you love to look at radiographs or
Images.
Images. That's what, it used to be x-rays, but now it's images. And you've got some that you brought that are really fascinating, and I want to go through them with you. So the first one, can you just talk about that? What that means?
So this is an informational flyer that quickly tells a patient that this is what the full body MR looks like, one slice from it, showing how it detects a brain tumor, pancreatic tumor, and then at the bottom is a prostate tumor, and the fact that it's no radiation, and it's, imagine if one image could save your life. This epitomizes that, and that you can get this in our Beverly Hills site in medical imaging or in Santa Monica.
The second image.
The second image is in case you're driving by, you can see our site. The one is a boutique facility next to Cedar-Sinai on Beverly, and then the other is in a medical building on Wilshire Boulevard in Santa Monica.
Okay. And this image about imaging for life, mind and body?
But basically, this explains that you can get two studies, a whole body study and a whole brain study. Not everybody needs the whole brain study, because in the whole zero-rad full body MR, we look at the brain, we look at the risks for aneurysm, we look at the risks for Alzheimer's. The whole brain scan, the mind, imaging the mind, is if you have severe anxiety, depression, chronic pain syndromes, intrusive thoughts, we can image the brain and see where those network abnormalities are with the potential to fix those by using neuronavigated modulation of the brain at Smart Brain and Health.
Is that the
That's
same
a whole
image?
nother discussion.
Is that the same image for Alzheimer's?
Yeah, well, we do the imaging to rule out Alzheimer's as well as part of that whole body MR.
Okay.
A whole brain MR, I should
say.
say.
This next slide is a comprehensive, looks like a comprehensive...
Yeah, this slide, which shows imaging the whole human, mind and body, differentiates us from some of the other places that do whole body imaging, who don't have the full spectrum of imaging capabilities. If you find an abnormality, you might need to do another imaging study to clarify what it is.
Of course.
And so we have the PET scans, we have the ultrasounds, we can do CT coronary angiography, and we have a full spectrum facility able to see everything, not only the MR. Yeah.
Okay, and here's another slide with zero rad scan, whole body MRI.
This is similar to the first slide, but just gives another look at how the whole body scan, one slice, obviously there's hundreds and hundreds of slices through the body in different planes to find the disease.
How far apart are the slices?
1 millimeter, some of them, 3 millimeters, others.
Wow, that is a lot of slices.
Yeah.
Okay, the next slide is the zero rad brain slide.
This is a very important test using AI where we can predict whether a person is at risk for developing Alzheimer's or in fact has Alzheimer's, early Alzheimer's. So this is non-invasive. It's done as part of our whole body scan, and 90% of people are completely reassured in that they have very high hippocampal occupancy, and they can remove fear of Alzheimer's from the things that they're worried about in the future.
Right.
So that helps a lot of people get peace of mind.
That's very, very helpful. And then the next slide, I believe, is showing maybe an aneurysm in the brain.
Yeah, this was a young person who had headaches, and fortunately we discovered this bilobe big aneurysm arising off of the internal carotid artery, the suprasellar internal carotid artery in the middle of the brain. You'd never know about it until it ruptured. And the full body MR, the zero rad scan, found this, and she had it actually treated at UCLA using minimally invasive endovascular coils that are put into the aneurysm, and she's cured.
So that coils, I mean, I don't know that you know this, they would know this, but it keeps
That's
it
what
from...
I did that as a training. I did interventional neuroradiology.
So it doesn't block the flow, it just supports the...
You need to have a very skilled team, and they're very good. I'm plugging UCLA here, but they're very good at endovascular treatment of intracranial aneurysms without blocking the main vessel, which would give you a stroke.
Right. Here is a very important scan showing the pancreas.
Yeah, this is a typical example of a painless cancer. In other words, this patient had no idea that he had a cancer, and you can see the multiloculated tumors arising off the pancreatic duct. This was a difficult case to treat because there were many cysts all through the pancreas from the head to the tail. Often they're localized just to one area, let's say the tail, and then we can, if they grow and become cancerous, you can at least remove portion of the pancreas, preserving pancreatic function. This was a dilemma in this patient because the whole pancreas was involved.
Right. Okay, and this next slide, I think, is the pelvis.
So this is an example of a giant, or I will say giant, let's call it markedly enlarged prostate, which is causing bladder obstruction. But in the multiparametric imaging, the red circle around the prostate shows, it's sort of a virtual biopsy. It shows where the cancer is. This was then biopsied and proven to be a cancer, but using only one needle instead of the 12 needles that the urologists used to use. So we were able to find exactly where it is on the imaging. They would confirm it with the biopsy with one needle.
Fantastic. Now here's your baby, the smart brain scan, whole brain MRI.
Yeah, this was an unfortunate young boy, an athlete, football player, talented 17-year-old, skateboarding without a helmet, and he was doing it in a swimming pool, empty swimming pool, and had a terrible fall, fracturing his skull, ending up with this massive traumatized brain area in the dominant hemisphere in the left of his brain. And he survived, and now he's in rehabbing, and we were able to do the functional MRI study showing the networks that were disrupted. The brain, fortunately, in a young mammal, is able to recover, and other parts of the brain take over the broken areas. And using TMS, we can stimulate areas of the brain to try and get that cognitive function back. And so he's in our program for traumatic brain injury, neuronavigated TMS, transcranial magnetic stimulation.
And TMS is not healthy with or helpful with Alzheimer's?
It's the same technology that manages depression and Alzheimer's, yes, to stimulate brain health.
And what is this last slide, the smart brain health whole body MRI?
Oh, this is what the TMS unit looks like. You sit in a chair and you have a device that is targeted over the area of the brain that you want to stimulate to ignite neuroplasticity.
No incisions.
No incisions and no negative biological, no radiation. So it's totally biologically safe. And if it weren't a bit expensive, everybody, especially you, would just do it. You'd have one here in your house because it's proven to help cognitive function and mood, and experiments done with...
Do you feel my mood needs improvement and my cognitive function?
Well, no. Even smart people do better with TMS.
Well, maybe I'll come in next weekend. So if I have a water or gas bill that's a little high and I'm depressed, I can come in and you can solve that?
We would say no, we're not going to help you with that. But we get a little depression and we'll help you.
No, I'm being more serious. I know exactly. But
I'm teasing.
Yeah, but you know what? I'm just so... I'm really excited about all these things that you're showing me because it's helpful to so many people and they all need to know about this. And I think it's one of those... there's shadows. You just don't understand what goes on and what's possible. And I'm just lucky to have known you. And it's been a wonderful time interviewing you.
Well, you've been my friend for many years. So it's just always great hanging out with you and talking to you.
Yeah. Thank you very much for coming on the show.
Thanks, Garth.
Thank you.